Hello, everybody. Thanks for tuning in. I'm Joe Shupp from the Medical University of South Carolina in the United States. It's a true pleasure and honor to be able to speak at such a prestigious conference, although believe me, I would much rather be there in person in beautiful Vietnam and Da Nang and have cocktails with you. I hope we can do that in a not too distant future. So let's together examine the topic of functional CT imaging of myocardial ischemia. For my disclosures, I have industry ties with the companies that you see listed here. Now let's first look at current CTA and the current evidence. We know the latest from the CONFIRM study that CT is a powerful tool for prognosis, especially if you combine features of coronary artery plaque with the degree of stenosis. We were a little bit disappointed by the results of the PROMISE trial. Everybody in the field was hoping that CTA would be a clear winner in that comparison between a CTA-based analysis strategy versus conventional testing. That unfortunately was not the case, which let many of us down. We had much better data from the Scott Hart study, for instance, showed that patients with the standard of care fared worse in terms of coronary heart disease or myocardial infarction than those who were initially worked up by CTA. So that is exactly what we are hoping to see. Last entry, the Ischemia trial, again reconfirmed us in our belief that coronary CTA is truly a powerful gatekeeper before anybody should go to the catheter. The problem that all these approaches have in this aforementioned studies is that we're dealing with the problem of anatomical assessment. That is something that coronary CTA shares with invasive catheter. Just looking at the anatomy and structure of a lesion in a coronary artery doesn't really tell you how severe it is and whether it has any effect on myocardial blood flow. So a lesion that is rather low in diameter can indeed be flow obstructive, whereas even 90% lesions can not be flow obstructive. So that's what we're dealing with. So we need to do better. We need to raise the bar. How do we do that? We look for lesion-specific ischemia with CT. And we do that because we know that patient outcomes are improved if only relevant lesions are treated that actually have an effect on myocardial blood flow. Traditional methods to detect lesion-specific ischemia were always based on functional nuclear perfusion imaging, an invasive test, possibly including fractional flow reserve derivation. What we're trying to do now is to replace this all with CT, with techniques such as CT-based perfusion or CTA-based fractional flow reserve derivation. So let's first look at myocardial perfusion. And to do that with CT is not a new idea. We're just applying new technology to an old concept. Those of you who are old enough to remember electron beam CT technology, that instrument was designed precisely for the purpose of measuring myocardial perfusion. It was only later hijacked for coronary artery calcium. With modern CT scanners, we have various approaches towards looking at myocardial perfusion. We have single energy CT-based static perfusions that sometimes allow you to detect old or even a fresh infarct. We have a dual energy CT that looks at the blood pool to find areas that do not receive enough blood. Or we have dynamic CT perfusion techniques that follow the bolus of a contrast material through the myocardium. So what is the goal? Here we have a patient who has a stenosis of the first diagonal branch. We want to know about this non-invasively. And this is the first patient who ever underwent a dual energy CT scan to the heart, and it was at my institution. The dual energy CT coronary CTA shows us the stenosis caused by calcified and non-calcified plaque, so we can see morphology. With dual energy CT, you're looking selectively for the presence of iodine, the blood pool within the myocardium. And you can also do that with dual energy CT by mapping out the iodine content within the heart. And the absence of iodine obviously indicates the absence of blood. That correlates beautiful with the traditional functional test of SPECT that you see here. And you can do that with modern machines with very low radiation doses, like here 2 millisievert for a perfectly fine dual energy CT coronary study. So that helps us to accomplish the goal of looking at both structure and function. We see the atherosclerosis, we see the stenosis, and more importantly, we see what those lesions do to the blood flow to the heart, mapping the iodine out to assess for perfusion defects within the myocardium. I'm always surprised what subtle technology we can detect. Look at this study, for instance. Patient has a myocardial infarction, as you can see on the MRI study. This patient also has infarction involving the papillary muscle. And you can only see that with structural techniques such as MRI or dual energy, whereas nuclear medicine studies completely miss that. Here's another example. This is reversible ischemia with a perfusion deficit in the anterior septum that goes away during rest. So picture book reversible ischemia. This is the dual energy CT study that gives us much more information. Yes, there's reversible ischemia, a perfusion deficit that's here during rest, during stress that goes away during rest as confirmed by the nuclear study. But we also see what causes this. We see that the left anterior descending coronary artery doesn't appear on our 3D volume rendering because it's completely thrombosed. We also see that a patient has a patent stent in the right coronary artery already. So structure and function, all with one modality. It's also important that we can put a number on what we're seeing. It's important to show that therapies that we employ actually work for our patients in a time of precision medicine, something very important. So we're able to put a number on healthy portions of the myocardium and on diseased portions of the myocardium and tell you in terms of milliliters blood flow per 100 milliliters tissue per minute what the perfusion rate is. Very powerful technology. It has been put to test by our colleague Dr. Ho from Singapore, where he showed basically the principle. This is a patient with a stenosis in the right coronary artery, which on myocardial perfusion imaging induces perfusion deficits that you can see here, and you can measure them compared to blood flow in healthy myocardium. When you put a stent in and blood flow to the territory was reversed, you see that now in the former defect, the blood flow is normal again, maybe even a little bit hyperemic compared to healthy myocardium. So point and case to measure and monitor therapeutic effects, these could be extremely powerful tools. Now let's look what we can do on the coronary artery level. Let's talk about fractional flow reserve derived from CTA. There are several methods. The original one is derived from computational fluid dynamics. That's a technique that's also used in the airspace industry to simulate flow around an airplane wing or in the wind channel for cars. The same principles are applied to estimate the pressure drop before and after a lesion based on a coronary CTA study, which is a normal diagnostic study, so nothing special. No additional medications needed, no additional scanning. Why do we want to do that? We know from the FAME studies that patients benefit the most if they're treated only if they have a lesion-specific ischemia. So if patients are intervened on that have normal fractional flow reserves, defined as greater 0.8, those patients don't benefit from intervention. whereas those who have lesion-specific ischemia with decreased flow values actually do. To differentiate those, what traditionally has been necessary is fractional flow reserve invasively measured to obtain that pressure gradient of more or less than 0.8. That technique is based on a fairly large and rigid instrument that I honestly would not want to have in my coronary arteries. Coronary CTA comes to the rescue. The first step of FFRCT analysis is the segmentation of the coronary tree. And based on that segmentation, the flow simulation is carried out, what would happen in that vessel during maximal ischemia. And that then helps you to determine the pressure values within that vessel and put a number to it to see how much the pressure drop is in this vessel. And you can also simulate what is happening if you were to put revascularization in that patient and treated that lesion with a stent. So you can simulate what the blood pressure the pressure in that vessel would be at that particular point. Clinical validity of that method was established in 3 prospective multi-center trials, Discover Flow, De facto, and NXT, which all showed very good results in terms of precision for. Main takeaway message is that it improves specificity over the visual inspection of coronary CTA alone. You see how the area under the curve becomes much larger, increasing the specificity and reducing the number of patients that are called falsely positive. That keeps a lot of people out of the cath lab. As I said, there was a high per vessel performance and high per patient performance in all 3 trials, although the data was slightly different. But that led to FDA clearance of this approach very early in the year of 2014. Meanwhile, FFRCT has shown its superior diagnostic performance vis-a-vis all modalities. These are results from the Pacific trial, where FFRCT, CTA alone, SPECT, and PET were compared for their accuracy for detection of lesion-specific ischemia. And you see that in all those categories, fractional flow reserve comes out the best. Specificity of SPECT seems to be a little bit better at times, but overall FFRCT is the clear winner. Clinical value was very elegantly demonstrated in the platform trial. The study design had one usual care path, and all of these patients went to catheter. The study group went first to CTA with FFR analysis. And if they had no obstructive CID by FFRCT, they did not go to ICA. The remainder went to ICA and was obviously treated as non-obstructive CID or was revascularized. Now, the results showed that by the insertion of the FFRCT analysis, 61% of the initially planned ICAs could be canceled, which is an 83% reduction. It is obviously a great win for non-invasive techniques. And even better news is that in this group, no adverse clinical events were observed. You can say it's good if ICA is avoided, but it's bad if patients die after that, like flies, but that's not the case. So it's a very safe technique to exclude obstructive coronary artery disease. And there was another observation. Those patients in the study cohort reported that they experienced a better quality of life, and the approach was substantially cheaper than the invasive approach. And that is rare in medicine, to have a medical intervention, especially a medical test, that saves money and makes people happier. We don't see that very often in medicine, and especially not in medical imaging. It seems like the cost savings are amortizing over time. there's an immediate cost savings, but that increases at 90 days and at 12 months. So even after accounting the cost for the FFRCT analysis. So this is a test that keeps giving and it decreases cost of care over time. Sometimes our colleagues in cardiology are wary if we do something imaging the coronary arteries, but they can rest assured that we're actually helping them. This is the effect of FFRCT on the efficiency in the cath lab. Weeding out all those patients who have non-obstructive disease, our colleagues in cardiology can focus their precious catheter suite time on patients that really need intervention, and they are not performing those money-losing mere diagnostic catheters that nobody really wants. So it helps their efficiency, which is a good argument to buy into. The advanced registry is one of the later pieces of evidence in favor of FFRCT. This looked at in excess of 5,000 subjects undergoing CTA in various parts of the world. The primary endpoint was the reclassification rate between a purely CTA-based versus an FFRCT-based management. These are the results. If you look at the initial management plan, just after having had a coronary CTA, there were a lot of questions. There were in excess of 2,000 patients where people felt additional information was needed, and only the rest was randomized to optimized medical therapy or revascularization. But after the insertion of the heart flow analysis, the rate of insecurity dropped wildly. There were only 121 patients left where people felt they needed more information. And again, this is a very safe technique. Look at this, we have a very strong predictive role of decreased FFRCT values for all MACE or for death or MI, versus basically it's completely excluded if you have an FFRCT greater 80. So there are no adverse events in that group. Again, a very safe approach. We've just concluded the PRECISE trial. The PRECISE trial is basically the same study design as the PROMISE trial, just on steroids, with the insertion of FFRCT. We have in excess of 2,000 patients in that trial now, and the data is locked. MUSC was fortunately one of the stronger recruiters in that particular study. So we're eagerly awaiting the results, and we anticipate that it will be much better and less disappointing in the initial PROMISE data. Let me show you some clinical examples. This is a typical history, 55-year-old male with 3 weeks of exertional chest pain. The coronary CTA shows a bifurcation lesion here at the takeoff of the circumflex and the left anterior descending coronary artery. This is a cinematic rendering of the coronary artery tree of this patient. This is the catheter angiography, which shows us that left main bifurcation lesion. And this is the FFRCT analysis that you see here. And we can see that obviously that is highly lesion-specific ischemia in basically the two vessels that are affected by bifurcation lesion. But something that we initially missed was became also evident that this patient actually has a 3-vessel coronary artery disease with also an RCA stenosis. This is how we manage patients at MUSC using CT-FFR. If you perform a CTA study, there are different outcomes that you can expect. Either you end up with high-risk anatomy, meaning a lesion greater than 90%, and those patients obviously go to the cath lab. Most of the time you will have an intermediate lesion, something between 30% and 90%. In those patients we perform FFRCT, and if that's pathologic, then those patients go to the cath lab. If it's in that gray zone of FFRCT between 7.6 and 0.8, patients are being placed on optimized medical therapy and reevaluated for symptoms 3 months later. If symptoms still persist, they go to the cath lab. If they don't have symptoms, they're being put on optimized medical therapy again. If you have FFRCT greater 80, despite the presence of lesions, those patients also go to optimized medical therapy, and if you have lesions less than 30%, the same pathway. The clinical value of FFRCT has been recognized to the extent that it was incorporated early into pertinent professional guidelines. That is also a record to be in the guidelines that quickly. And that's not only true for the United States, that's true for UK, that's true for the European Union, and true for some Asian countries where FFRCT is being placed front and center in the analysis of patients with suspected coronary artery disease. So we increasingly recognize that CTA is the ultimate gatekeeper to the cath lab, and CT-FFR is becoming of increasing importance for CTA to perform that role. And with that, I thank you kindly for your attention. I hope we see each other in person soon. Stay safe. Take care.